Thank you. So I decided to go this way with, the computer. I thought it would be easier since I could show you, and we just start with this because I have it handy. I'm allowed to do this because I'm the HIPAA person. I can show you my own test results. I got yelled at once in a school about 10 years ago. It's like, are you kidding me? Idiots. Okay. So, for instance, this is what we're going to look at white blood cells a bit today and finish up. And then in the lab on Thursday, will get on top of this electrocardiogram stuff. I just was unable to do it. I don't understand why. But take a look. So when you're looking at a CBC means complete blood count, red count, white count, platelets, variety of other things that are a part of it. And for many of you going in, where the F is everybody else? Yeah, I know. I'm not blaming you. I'm not that interesting anyway. And my wife tells me that. But we want to look at some of these numbers to give you an idea about what's going on. So, and it's more elaborate than that. So when you get a hospital-based blood collection like this, so neutrophils typically we look maybe between 45 and 65 every lab. So maybe it's a Scotia low. Remember, these are snapshots when they take your blood. Lymphocytes are 20 to 40. So these are still within the normal range. Monocytes, maybe that's a smidge high. EOs, that's around normal. Basophils, and we're going to do all these today. You rarely see a lot of. But this is the big numbers are coming up. Now, these ABS ones that you can see there, these are immature forms. And again, the suggestion when you see either an excessive amount or an insufficient amount, if there's an excessive amount of immature forms and there's signs of infection, then that clues you in that you're in an acute phase. And if there's insufficient and there's signs of infection, that suggests that your immune system is compromised. You're not making so all of this it's very relevant stuff from a doctor perspective. But little looks at that. If you're interacting with people, I mean, there's a certain extra amount of caution that not that you would not take appropriate caution anytime you're working with somebody, but when you have somebody who's compromised to any degree, it's much more significant. So these ABS ones. So here, this one says high. So this is in August. Again, it's random. And a lot of times when we see something that's random, slightly out of the ordinary, you kind of go, okay. You see, it's not terribly speaking. Now, where this is a normal white. So in the presence of a normal white count, you wouldn't get very excited about that. This is an ongoing problem since I've had 2 major stomach surgeries, any number of transfusions, which we're going to get to at some degree of length as to which I've consistently run relative, and these have dropped a little bit. So I don't know whether this is something, and I'll have it checked again. But that was a concern, and they were really looking at the possibility that I had what might have been some variation of pernicious anemia having to do with B12 levels. So what gave that away? You have low red counts and low hemoglobin. That's not ridiculously low. It's just a skosh under. But generally, men, you would expect it to be a tad higher. The hematocrit is normal, so the range. So it's not like I'm terribly anemic. This MCV, these are called the Wintrobe indices. Not that you have to know any of this; it's just informational. But they indicate they're a little snapshot to look at the volume of the cell. So it's a bigger cell, and so when you see a larger red blood cell, that's insufficient maturity, and that's usually B12 or folic acid. And they ran my B12 levels, and I'm supposed to get another one. I just haven't felt like going to the hospital and coughing in a way. And platelets, they just give you, typically they'll just say adequate, doesn't really matter. So that's that. Now, we're doing the blood unit, but while I'm here, it doesn't hurt. I'll go back and show you what chemicals. This is what they call CMP, or Comprehensive Medical Panel. The C-reactive protein is somewhat of a non-specific test for arthritis, for inflammatory changes, for inflammatory markers. So they monitor my progress with that. So these are electrolytes: sodium, potassium, chloride, and carbon dioxide, or bicarbonate is another one that effectively you're measuring with that. Urea, nitrogen, that's your kidney's job to get rid of nitrogenous waste materials. This is the largest of that component. We'll get to that. Glucose, and again, it's a snapshot. This is not fasting, but if your random glucose is in the normal range, it's unlikely you're a diabetic. The urea nitrogen and the creatinine are the best measures, because that's another nitrogenous waste, for being able to assess quickly if the kidneys are working properly. If those start to go up, kidneys are not getting rid of it fast enough. That's true. Calcium, alkaline phosphatase, which plays a significant role in bone, cellular damage, bilirubin is liver, proteins, liver, albumin, liver. So you look at a lot of those to see if your liver is functioning excessively, if there's been some damage, and it's so extraordinarily important. Anion gap is a measuring of the electrolytes, and it should fall into this typical range, and the albumin to globulin ratio. So, and what they do these days is with these numbers, they calculate your osmolality is really important, because it means that your tissue fluids and your blood should all be roughly the same amount of stuff dissolved in it. So it's not pulling water out of the cells or pushing water into the cells. And it should be around, and you're going to see when you get to the kidney unit, around 300. Maybe, and you can see the range here, 281 to 307. And from all of those numbers, this is a significant calculation for people who, as they get older. It's estimated glomerular filtration rate, and that's a measurement of kidney function. So this is, again, using blood tests, a very quick snapshot to tell you if there's a problem. As folks get older, their kidneys don't function necessarily as well. Obviously, mine are doing fine. Now, my brother-in-law, who is retired Air Force, when he visits here, he lives in Tucson. When he visits here, he's got a bike that he races around North Park every morning for like 2 hours. He's got to have the same waistline he probably had when he was 20 years old. He's 2 months younger than I mean, he's the fittest looking person you ever saw. And for a while, all of a sudden, he was showing these results that were below 59. And they're worried about having some kidney problem. I think it was just not there anymore. Comparatively, they've corrected themselves. But he's one of these, fitness freaks at 72 years old, which I am not. I walked the dog this morning. For you late arrivals, I'll show you. Where's the dog? Should be up there. Where did my dog picture go? That's terrible. All right, I give up. Moving on. Up, there he is. So, moving on. It's a dog. So I just wanted to show you that before I get started with the PowerPoint stuff. And so I just sent everybody, for the later arrivals, pardon me. I just sent everybody the link, and I have no idea why we're not being able, and my other class is in the same situation, so hopefully we'll be able to correct that. Let me go through this. I have an idea where we were, because we did the red cells, and we were just where I'd stopped it, as my recollection was at sickle cell anemia, correct? We hadn't started that yet. And it's important. We had looked at those familial Mediterranean anemias, which often are referred to as thalassemias, not that you have to know that. But again, they're genetically based. And again, if you take a course in genetics, then you really, because they're pretty well understood as a sickle cell, the nature of those particular problems. So it's sort of an easy teach. So here's where we looked at the different kinds of anemias and blood loss and pernicious. I was taught renal, again, people with compromised kidneys. And so there's a lot. Now, these are the ones I was talking about. Mediterranean, again, it could be North African, it could be, Southern European, Italy, Greece, Spain. There's a number of variants that are there, and sometimes it is very severe, what they call major thalassemias, that they do require now transfusions. We made a lot of improvement. The one that undoubtedly, that you all should be familiar with, because it's more common than you think. And for years, it's a recessive and autonomic, not sexual linked. It's a not autonomic. it's a standard recessive disorder. So, in order to have quote unquote sickle cell disease, you need to have both recessive markers. A lot of people carry the trait. The trait is potentially as damaging. And the classic example is a guy who played for the Steelers, you see on ESPN all the time, because he never met a microphone he didn't like, named Ryan Clark. So he's a major contributor on all sorts of ESPN shows. And he had, and they knew he had the trait. He went up to Denver where there's lower oxygen availability, played a very arduous game, and why the Steelers always had trouble in Denver because he could no longer play there, and managed to rupture his spleen and his gallbladder and had to have emergency surgery. And he nearly died. I can't even tell you how many athletes we've had where they have either died or suffered major damage because the coaches, ignored the fact that they had sickle cell trait. We used to think that the trait was just something that you carried. Now we understand that if you're doing high output athletics and you lower your oxygen, you have so much oxygen consumption that you're in greater need, even at sea level. Because a major case happened in Florida at Central, the one in Orlando, whatever that is, Central Florida, I think that is. There was a coach there who was, because they developed into a very good football program. The coach just was ballistic. And what's the distinction? As a genetic disorder, one amino acid out of place. And what happens at lower oxygen levels, the red cells sickle where it derives its name. You'll see the illustration, and they clump together and they clog blood vessels. So one of the things we see a lot of are what causes so much pain is the blood vessels clog going into organs. So they're doubling over in pain. They clog in the extremities. When I was down in Richmond for a summer, and I was working at a clinic that specialized in ulcerations, skin defects, mostly in the lower extremities, for people who had that, and I learned a lot about wound care. They were just in tremendous pain and very, very difficult to take care of all these folks that were there. You thrive on that. If you go into a medical career, you thrive on that stuff, seeing interesting stuff that you haven't seen before and learning a lot about it. So oxygen delivery pain, ulcerations, which are defects in the skin from absence of circulation, all of that's part of it that's there. So sickle cell anemia, mostly people of color in the African malarial belt and their descendants. Interestingly, because it affects the hemoglobin and malaria attacks hemoglobin, typically people with malaria are not as susceptible, okay, and to somewhat protected, which is interesting. And there's certain aspects of the alteration in the hemoglobin that's very interesting in treatment. So it does not, possible benefit people with sickle cell do not contact malaria. And that's why I should have said it that way. Whenever it still is a major killer in sub-Saharan Africa, okay? 2 copies of the particular things. We have both genetic markers that are there. And again, and so as you begin to see those with the trait even can survive. Malaria, the largest killer in sub-Saharan Africa, and most people have a misconception, and they think, it must be AIDS, because there's about 30 to 35% of people are HIV positive. It's not, it's malaria still. So malaria, HIV, AIDS, and interestingly enough, measles after that. And I'm sure all of you have gotten MMR when you were little, measles, mumps, and rubella, but there's a lot of distrust for vaccines in sub-Saharan Africa or equatorial Africa, because most of us sincerely believe, and there's a lot of evidence, that HIV developed from a terrible attempt to make polio vaccine on the cheap in Africa via diseased monkeys. And so we created diseased monkeys with a virus, inoculating with a polio virus, to lack of a better term, hybridized. Not unlike what happened with COVID, is you have multiple viruses or multiple species with viruses coming together and causing this terrible, terrible disease. So, and it's something I do a little bit in micro. You guys have micro yet? I asked you that before. The next term, next year, every so often they let me teach micro. I'm teaching in the spring. It's my favorite course to teach. So all of those things. So treatment transfusions, nitric oxide, which is a potent vasodilator. So if the vessels are blocked, it opens them up. Okay. Hydroxyurea, which induces fetal hemoglobin, which doesn't sickle, is an interesting way to treat it. Stem cell and gene therapy, etc. So we're seeing a lot more ways to treat that. Whether or not bone marrow transplantations are effective, I do not know. I don't have an answer for that. So I wish I could. And this is the classic example of the sickle cell, one amino acid. So when we talk about mutations, this is an isolated mutation, but it can cause tremendous damage. So just one alteration in an amino acid chain can do that. Too many red blood cells, polycythemia, thick, viscous blood, comparatively rare, what they call polycythemia vera, which vera means true, Latin. So when you verify something. So when it's true polycythemia, that's surely a bone marrow cancer in the red cell line, and you just have to keep draining off blood. Most of the time it's secondary, altitude, increased erythropoietin. We see a lot of problems with that with folks who have respiratory problems, chronic respiratory diseases. They don't get enough oxygen in. Their body is being stimulated to make more red blood cells. The problem is they're still not getting the oxygen. And now you have thick blood with not enough oxygen. It's tragic because the heart has to work harder to push that around, and the lung can't deliver the oxygen. So, I mean, the combination of chronic respiratory disease like emphysema and it's almost like a vicious cycle. It just keeps getting worse and worse. It's really difficult. So, and then the blood doping of athletes is something that's been around for a long time. And that brings us to really most of today's topic is the white blood cells. We visit this in immune as well. White blood cells, known as leukocytes, come from the bloodstream, and they change. Some of them stay identical in the bloodstream as what they are, and I'll go over each one of these. There's 5 major categories. You're going to see how we classify them. So they're the only true formed element that's really a cell with nuclei and organelles. They're less than 1% of the blood volume. The vast, vast majority are red blood cells and then platelets. You can see the normal count. Mine was like 6.4 thousand. It's usually in this range. If somebody gets, like, for instance, what would you see with somebody with acute appendicitis? Relatively common diagnosis. Probably somewhere between 12 and 14,000 white count, 102 fever, abdominal pain, difficulty in urination. It's probably about what you would be sort of the symptom complex that you might identify. So to give you an idea, so it doesn't have to raise that much. I mean, if somebody gets to 15 or 20,000, they're really sick. They're really sick. They're going to be in the hospital. Infection. Okay, so they are in the bloodstream and chemical, and sometimes they just escape normally to go through all the tissues, and they're there on surveillance. They're part of your defense system. Part of our immunity, and we do an immunological unit, are these white blood cells that are constantly present in your tissues, around the openings, your nose, and your gut, genital urinary areas, any place where there's an opening into you. You have a large clusters of immunological tissue. But what happens when you're infected? You get an upper respiratory infection. Cells get damaged. When cells break up, they send signals throughout the bloodstream, and what they cause is increased blood flow, and they alter the capillaries so the little openings get larger. And what the word here, diapedesis, is it allows the white blood cells to kind of slither through these little openings and go to where they're needed to fight infection. And when I say slither, amoeboid motion is kind of like a baby scooching around on the ground before they can really crawl or walk. And chemotaxis means these chemicals have summoned them. And so the chemicals, not only do they summon it and they're attracted to the chemicals, the chemicals influence blood flow in those openings that are there. So that's one of the, and we look a little bit more thoroughly at that when we get into the immunological system, which, to be fair, most students that I teach in this course find that the most difficult unit. I basically dedicate a whole test to that. I'm sure you're looking forward to it. So anything over 11,000 per microliter, normal response to infection, two lines, granulocytes and agranulocytes. They all have granules. It's somewhat of a misnomer. The question is whether they're visible or not. So the granules are the chemicals that help to fight the infection. Think of it that way. There are 3 cells in the granulocytic line, okay, and there's 2 cells in the agranulocytes. Again, the granules are in there, but you can't see them microscopically when they sting. And this is the classic one. It's one of the few silly kind of mnemonics that never let monkeys eat bananas, which I think is cruel and unusual treatment. Personally, just saying. I have a kick-ass recipe for banana nut bread. Oh. You bake? Oh, I just got a big bag of yeast from Amazon. We're making bread. My wife watches this. She's like a farm lady, and her name's Patara. If you ever YouTube it, she all this great stuff. So she sent me that. I do the baking part. So never let monkeys eat banana. These are the 5 major cells. There's other variations: neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And that's order of frequency. So if you recall looking at my white blood count, neutrophils were the most, then lymphocytes, then monocytes, then eos, and basophils. And you will see them all here. So this is what it looks like. So not drawn to scale. So in a white count, 50 to 70%, mine were like 48. Neutrophils, eosinophils, mine were a little high, 2 to 4. Basophils, you're lucky if you see one. Agranulocytes, the ones without the visible granules, lymphs, 25 to 45, monos, 3 to 8. Mine were a little bit high. Who knows? And here's what they look like. The granulocytic line, you can see visible granules. You're looking at 2. Granulocytic line always has nuclei that are lobes. Multi-lobed, bilobed. What does that mean? It's still one nucleus. Okay? So the nucleus, think of the nucleus as a ball. And the best way to think of it, how it gets lobes, is a balloon, and you're made a balloon puppet. Balloon puppet? You had a birthday when you were little. They made balloon puppets. See? Balloon puppets. So it's one big nucleus, but it's like split here, and this will have a minimum of 3 to 6. If you see 3 lobes, it's a neutrophil. Neutral means neutrally staining. So it's a pale, it's not distinctly red or distinctly blue. Classically, they call it a lilac color, whatever that is. Guys don't know from colors. Orange is a fruit, not a color. Peach is a fruit, not a color. It's a guy thing. Round is a shape. My eldest sends me all that stuff from the Navy. All those new things. He's one of those. Eosinophils. Eosin is one of the stains. Eosin turns things reddish in color. The nucleus is bilobed. Eosinophils are very significant. So let me give you the lowdown on this. Neutrophils, we call them bacteria slayers. When you have a bacterial infection, you have strep throat, you're going to have a bunch of neutrophils. Another name for the neutrophils, okay, it's got a fancy name. It's called polymorphonucleosides. I know. That's why we call them neutrophils. Poly, many, morpho, shaped, nucleosides, many shaped nucleus, 3 to 6 lobes. They are high when you have a bacterial infection. Eosinophils are high typically with allergic reactions and sometimes with parasitic infections. A parasitic infection would be like having your dog having worms, would be a parasitic infection. Malaria, interestingly, is a parasitic infection. So we begin to see what's called an eosinophilia with that. So, I mean, we have the Seresto collar on the dog, and he gets the heartworm medicine. That's, and one of the signs that your vet would look for would be an eosinophilia. Sometimes we see it raised in allergies as well. My middle child, when he was little, had a lot of digestive and respiratory problems. He had something called eosinophilic gastroenteropathy. He had an abundance of eosinophils, probably from allergies, because he was, couldn't tolerate dairy and stuff like that. Now he can, so who knows. Basophils, very much associated with allergic responses. Neutrophils and eosinophils, when they leave the bloodstream, they stay like that. Basophils form a very interesting cell that we're going to visit a lot in immunology. So somebody with asthma, and we all do, they become something called a mast cell when they leave the bloodstream. Mast cells are typically cluster around respiratory passageways for folks with asthma. If you know somebody with significant allergies like peanut allergies or oil allergies that are potentially deadly for anaphylactic shock, they have an unusual amount of those clustered in their respiratory. Somebody who gets hives, they'll cluster under the skin. Most people know somebody who has an EpiPen that they have to carry around with them for bee stings and things like that. And we talk about that a bit in immunology. So those are the granulocytes. The next most common after the neutrophils are lymphs. Lymphocytes look like a great big nucleus with a scant amount of cytoplasm, typically pale and blue. Okay, all of these are larger than red cells, as you can see. And what's interesting about, typically when you see a lymphocyte like that in the blood smear, it's a T cell. We'll get to the distinction when we do immunology. But lymphocytes are elevated when you have a viral infection. So if you had COVID, hopefully not, okay, and they had done blood tests, they would have seen lymphocytosis. That would have increased over that 20 to 40 roughly. And then lastly, monocytes, when they leave the bloodstream, and they're the largest, they have a very distinctive kidney or U-shaped nucleus. It's got like a little indentation. They're the largest. Again, even though to me it looks like you can see granules, but it has more cytoplasm proportionally than the lymphocyte. That morphs or changes when it gets into the tissues into the very famous macrophage. And macrophages are what your body basically does is attacks and destroys invaders, damaged cells, damaged tissue, creates little fragments, and macrophages go around and gobble up the debris, and you make new ones. I've always said I want to be reincarnated as a macrophage. All you have to do all day is eat. That's what it means, big eater. There are worse things that you could have. The dog is a big eater. So here you are. Larger and short-lived. Some of these we're talking about hours to days. Lobed rather than circular. Granules. The famous stain is called Wright stain with a W. Proper name. To some degree, they're all phagocytic, but the phagocytic ones, eos and neutrophils, are really highly phagocytic, as are the macrophages. So 50, 70%, twice as big as a red blood cell. It stains both acidic and basic. That's why it sort of is in the middle. That's not neither red nor blue. Red would be acidic, blue would be basic. Enzymes, proteins, they latch on to something, they release these chemicals and destroy it, the bacteria. That's what they do. And there's a whole thing we do about that with immunology. PMNs are polymorphonucleosides, 3 to 6 lobes. Bacteria slayers. Think of it this way. When you did the cell in AP1, did they talk about peroxisomes? A little bit, lysosomes and peroxisomes. Any of us who breathe air, okay, we make what are called toxic derivatives of oxygen that are nasty. The modern cancer and aging theory revolves around them. So people who take drugs, people who smoke, you make more of those, and they become, and proportionately speaking, peroxisomes have enzymes that change those from being highly toxic to less toxic. Hydrogen peroxide is less toxic than some of them. And then eventually hydrogen peroxide is easily converted to water and oxygen gas. Think what happens when you put peroxide on a wound. It bubbles up. It stings because the reaction is rapid, but it bubbles up. And that's oxygen gas as the bubbles. So what happens here, these cells have this, and what happens, they're released. And so the defensins are like poke holes, let's say, in the bacteria, and then they release these chemicals to sort of what, very clever. It's like, and boom, love that. I'll remind you of my teaching philosophy. If I'm not enthusiastic, why would you be? Right? I mean, how many professors do you have? I'm not casting aspersions that sit there and go, leukocytes, neutrophils, multinode nucleus, pair red and blue cytoplasmic granule. You're thinking of one right now. I'm not like that. I'd bore myself. It shouldn't surprise you. I was that little kid. You all had him in school, sat in the front of the class. The teachers begged them to be absent. It's like, could you ever be sick a day, Lewis? No, I'll ask my mom. She doesn't want me to be at home either. And she works. She's not even at home. I'm that little kid. The obnoxious little kid teachers hated. Now he's the teacher. And goes around, comes around in life. I love that. Eosinophils, small amount, 2 lobes, look like earmuffs, if you will. Red staining granules. They dissolve parasites with those granules, but they play a role in allergies and asthma, immunological responses that you can see that are there. Basophils, when you look at a smear, you're lucky if you see one. 2 constrictions, it's typically bilobed, very distinct purplish black granules. The big player is histamine. So most of us, we have an allergy or you take an antihistamine. Histamines dilate blood vessels. So that's why your eyes water and you have a runny nose. So that's what histamines do. They are pro-inflammatory. They make inflammatory, they widen blood vessels, they call other white blood cells to the site. And effectively they become mast cells when they get into the tissues. So they look like that. You'll see the mast cell looks identical. The ones without the granules that are visible, lymphs and monos, spherical or kidney shaped, lymphs, circular, lots of places. They circulate in the blood. We see clusters of them in the tissue that underlies almost everything, all the lining tissues. Those are white blood cells because they're immune surveillance. When we get to the immunity, we'll talk about T cells and B cells because they're the powerful arm of your immune system, whether you have a relatively minor viral infection or you have a life-threatening infection. They're the big players. You can see it here. Monocytes, largest. The U are kidney shaped, differentiating to macrophages, actively phagocytic. They just play a role in all of this type of stuff. So they're really, and when we get to the immune system, it's rather complex. I'm not going to go into all the complexities, but there's like a co-stimulatory role. So that's what they're talking about here. You need all of these for your immune system to function properly. And it's very, very difficult. The immune system is really if you ramp it up too much, it can cause problems. And if you suppress it too much, it can cause problems. And unfortunately, I'm someone who that has happened to over time. And so moving on. White blood cells stimulated by different chemical measures. When we get into the immune system, we'll talk a little bit. I'm not going to ask you to remember all the names about interleukins and colony stimulating factors. And basically, these are the most important part for you folks, the cell line itself. You have lymphoid cell lines and you have myeloid cells. So when you hear about leukemias, they'll either say acute or chronic lymphoid leukemia or acute or chronic myelogenous. Those are the 2 lines. So if you have a lymphoid, it'll be lymphs or monos. If you have a myeloid, it'll be neutrophils, eosinophils, or basophils. And there's a lot of variations. They'll show you the cell lines. And we're not going to go through all of that. The immature forms, those band cells, that's what I was showing you before when I looked at those blood tests of mine. The band cells are the ones, it's like if someone's putting those out, they're in the middle of an acute infection and your body's losing because your bone marrow is pushing those out. And the way it was always explained to us, it's like a military action. Your white blood cells are your troops. Well, and if you're putting out troops who aren't ready to fight, haven't been trained, don't have the proper weaponry, they're going to lose. So and really that's part of the problem. So, and without going through all that jazz, this is what the lines look like. This is the leukocyte line that you can see over here. So they'll start. You have different lines. You have the myeloid line, makes eosinophils, basophils, and neutrophils. The lymphoid line effectively makes monocytes or macrophages, and eventually we'll get to typical lymphocytes, and they're either going to be B or T cells. We'll get into more of that. Okay. So we use these clinically. Okay. There's a lot of immunological stimulants that you're trying to utilize to stimulate bone marrow, to try to deal with AIDS patients. We have the capabilities now. Most of these are proteins, and we can make proteins in the laboratory. So when you hear about somebody, whether it's human growth hormone, that someone might be taking, maybe a child who's very, very small comparatively, and they have to boost that. That's a relatively simple thing. Making insulin is a protein. That's the first protein that was made in the laboratory, what do we call a GMO, through a genetically modified organism. So when you hear about that, that's where they're coming from. We've tinkered with a living thing to make it do something for us. Whatever your feeling is about that is a different issue entirely from an ethical perspective. But for instance, I take a substance that you'll see advertised on TV called Humira. Okay, Humira is an agent that's used to treat certain kinds of inflammatory arthritis. I have a variation of psoriatic arthritis. So that basically, and we'll look at this in the immune system, and I'll go over it again. It attacks something called tumor necrosis factor, which is something that helps you not form tumors. So if you're fighting it, you're more of a risk of forming tumors. So it's like this. You can try to boost your immune system, but if you boost it too much, it can cause problems. And if you suppress it too much, it can cause problems. So it's all that delicate balance kind of a thing. That's medicine 101. Really the way we look at that type of thing. So leukemias, and the one that affects college students more than any high school students, mononucleosis. Mononucleosis is a viral disorder. It's typically from a herpes virus, not like a cold sore type of herpes virus, neither oral or genital herpes. It typically comes from a virus called EB, or Epstein-Barr virus. That's very easily spread through secretions. That's what they call it, the kissing disease. And it targets an increase in what are called mononuclear forms. So it increases lymphocytes and monocytes, not only monocytes. Okay, and there's lots of things that can play a role with it. And certainly there's a lot of medications, a lot of cancer drugs, steroids. If you know somebody who has to take those for a particular reason, they're called glucocorticoids. We talked about those before. They can suppress the immunological response. It's great if you're trying to fight somebody with an arthritic flare, but it's bad if you use it too much. So it's that fine line. Leukemias, basically overproduction of white blood cells, named according to the line, myeloid or lymphocytic. Acute are not great. The prognosis is not nearly as good, even with stem cell. And chronic is, by definition, slowly advancing. And if you want to paint with a broad brush, you can get children versus adults. Acute forms really have to be treated very aggressively because they don't have a good prognosis. And that's where, when we started looking at bone marrow transplantation, that has helped a lot. So, internal hemorrhage, overwhelming infection. So If you think of what happens with folks when their immune systems don't work, think of somebody with AIDS. Basically, the problem is particularly overwhelming infections. They can't cope with what you and I would cope with. A relatively innocuous infection would destroy them. It's just unfortunate. Here's the mono nugget, more in young adults. There's the Epstein-Barr. It's called HHV, human herpes virus 4. I go over that stuff when I do micro. High numbers of typical agranulocytes. So it's lymphs and monos, just only mono. But they name it because they're mononuclear forms. They don't have that segmented nucleus. And all those things are part of it. And typically, it's the problem with herpes viruses, before I get to platelets, the problem with herpetic viruses is once you have them, you have them. Okay, when you get, and hopefully they explain that to you, when whoever you does your micro, when you're exposed to HPV, it's you don't get rid of it. It doesn't mean it's ever going to affect you again. It could be in one isolated exposure, or it could recur frequently. And a lot of that is there's so many factors. Immune health, genetics play a role, lifestyles play a role. Herpes viruses are the same way. Nearly everybody's been exposed to the cold sore virus, oral herpes. By the time you're adults, basically, not everybody gets them. We don't know why they come when they come. My first wife, when she was in nursing school, when we only had one CCAC campus down on the north side, the Allegheny campus, she got mono. She was really sick. So I think she missed a whole year of school. She had a recurrence. So let's say she graduated high school in 68. So about 20 years later, 89, 21 years later, she had a recurrence of adult mono. For 6 weeks, she couldn't get out of bed other than to basically crawl to the bathroom, which thankfully is on the same level. I had 3 little kids, ages 3, 5, and 6. So I had to hire somebody to watch them during the day while I practiced. And then I'd come home at night and take care of the kids. She couldn't, 6 weeks. So recurrent mono in adults, any of these viral disorders that come back and clobber you as adults are much worse. So if an adult with measles, an adult with chicken pox, awful. Just letting you know that. Which brings us to the clotting aspect of things. Oh, you'll love this. As long as it's working right, it's great. Okay. Blood clotting is interesting. It's mediated by these little fragments called platelets. They come from a giant cell called a megakaryoblast or megakaryocyte, as you can see there. And it's like this cell goes through reticular fibers that act like a strainer and little fragments come out. And so it's got cell membrane and granules. No nucleus, they're just little fragments of cytoplasm with granules and little bits of membrane. That's about it. So they're tiny. They have a lot of chemicals. These are chemicals, and you probably heard some of these names. Serotonin, which is a neurotransmitter in the bloodstream, it has interesting effects. It can accelerate blood clotting. Calcium plays a role everywhere. Calcium is an enormous player, and it's extraordinarily important in blood clotting. A variety of other enzymes, energy factors, and something interesting that we don't get into in this course called platelet-derived growth factor. I told you I had a lot of experience in wound healing starting way back in 1976. Platelet-derived growth factor, if you see wound healing clinics, okay, or if you work in a facility that has them, and most of the big hospitals do, they use platelet-derived growth factor because it increases the healing of wounds with connective tissue and epithelial tissue. So it's not been around that terribly long. It's been around forever, but we were able to start to make it and harvest it from your own blood and use it on wounds to accelerate it. I graduated with my doctorate in 77. The first time we heard about it was 1990. It was at a conference in Erie when we started to hear about this. Not in Erie, rather in Hershey, at the medical school. And all of a sudden, the guy's getting up there and he's saying, I have some really important information. We're all sitting there like amazed about this platelet-derived growth factor. So it's not, we're talking in the last 30 years. So what they do is they seal breaks in blood vessels. The misconception is that it's because we're injured. We get a cut. We scrape our knee. Those kinds of things. That's certainly our blood clots that way. That's not the most common way that it occurs, unless you're accident prone or like me, what we call in my parlance a klutz. My wife will tell you. Okay. Those kinds of things. I'm happy I don't fall all the time. Most of the blood clotting you do is repair of these miles and miles of roadways that are blood vessels. Our blood vessels are a series of roadways that are traveled by all those cells, all that plasma, everything else that's there. And it's like any roadway, the more, look at our roads here in Pennsylvania. What do we get? Potholes. Effectively, most of your blood clotting is dealing with tiny defects. And you're going to see there's two systems. The intrinsic system, which works very slowly and deals with all those potholes in your blood vessels, imperfections, and the extrinsic system, which is when you injure yourself. That happens much more rapidly because you're much more likely to have a significant bleed from an injury than some tiny capillary that's got a slight imperfection. Okay. And they both basically work the same way. They both, as you will see, head in the same direction. So an old saying that you hear all the time called all roads lead to Rome. We're going to see all roads lead to a common pathway for blood clotting. That's there. So they form a little plug, particularly for breaks in blood vessels. That's the most common one. They are inactive. The lining cells in your blood vessels make a chemical that we're really just starting to understand called nitric oxide. So nitric oxide keeps blood flowing. It keeps it from clotting. It keeps blood vessels wide. You saw it a little bit before with sickle cell. People can inhale it or use it in some other form to try to make this. Nitric oxide is very, very interesting chemical and it plays a role in the growth and development of the brain. We're really just starting to understand it. Okay, and prostacyclin is another one of those. So we inherently produce things to try to limit the clotting of our blood unless there is a problem. It's sort of the best way to describe this. So now it's not the same as nitrous oxide, which every so often you go to a dentist and we used to call it laughing gas, which is an analgesic. It kind of makes you, you're not quite as all bent out of shape about, having a dental procedure or something like that, or even an in-office surgical procedure. A lot of my colleagues used to use that stuff all the time. Because it was sort of allay their apprehension. I didn't. Platelets are regulated by a variety of things, and we'll go into this. They're formed by that megakaryoblast or megakaryocyte. Basically, what happens, the cells divide, but they don't separate. Mitosis is generally we're making two cells that are identical. Same thing's happening here, but they just don't separate. They just keep getting bigger and bigger. Okay. And eventually they break off into these little fragments that are there. They don't last very long. If you saw on my blood test, basically they're in a range of about 150,000 to 400,000 per microliter. And a lot of times in a blood test, they'll just say adequate or normal. So as long as the number's in the normal range, it's fine. And this is what they kind of look like. The cell gets bigger and bigger, giant, and then little fragments break off as it kind of strains through reticular fibers. And they're just showing you all the different cells that are there. So the whole idea of clotting is this: hemostasis. Stasis means to stop or to slow. Hemo is blood or bleeding. So when we talk about adequate hemostasis in surgery, we'll make a cut in somebody, we'll clamp it, we'll tie it off, we'll cauterize it. That's called hemostasis. There's a little clamp, a little device. It looks kind of like a scissor with except it doesn't cut. It's called a hemostat. and it grabs onto things, and we put that on, and we'll cauterize directly on that, or do hand ties with it. I haven't operated on anybody in more than 20 years, don't know what they're doing today. Unfortunately, I've been on the wrong side of the operations. Never there. So they're going to show you what happens. You have to have clotting factors to play this role. What they do, it induces a vascular spasm, plugging of platelets, and then it clots. We'll go into more detail, but this is just, so there's been an injury. So blood vessels respond almost reflexly. Whether you fell and cut yourself or whether it's a defect inside, they begin to constrict to limit blood loss. So direct injury to the smooth muscle underneath the blood vessel, and we're going to look at blood vessels in both in lecture and lab, chemicals that are released, pain reflexes. Smaller blood vessels, it's a lot easier to get the bleeding to stop than larger ones. If you ever had a big time cut, and you see it's all spread apart, and you're saying to yourself, I better get to the emergency room because I'm going to need stitches or Med Express. You can typically tell that has to do with the sizability of it. So it's very useful in small blood vessels and large ones. A word to the wise if you haven't heard this before. Pressure stops bleeding. Firm pressure by the clock, 10 minutes. 10 minutes is a long time when you're holding something. When you say by the clock, amaze yourself. See if you can do it. Just squeeze your hand against your hand for 10 minutes without looking at the clock. Whenever you feel like, it's about 10 minutes, it's probably about 4. Time goes much more slowly when those kinds of things happen. It's like the Steelers game when they're winning and you just hope the clock runs out very slowly. When you're losing, it goes very fast. So platelets, typically what does it inside of a blood vessel, underneath the lining cells, underneath any lining cell, there's a layer of connective tissue called loose areolar connective tissue. The principal fiber that's there is collagen. When collagen is exposed to the bloodstream, platelets adhere to it. That starts the process. So, and then what happens, the prostacyclines and nitric oxide secreted by endothelial cells typically are not being made anymore. There's a factor called von Willebrand's factor that stabilizes it. Von Willebrand's disease has about 9 or 10 variations. Some folks don't have that. My first wife didn't have that. I think I mentioned that to you, that when she had surgery back in 81 and she had an internal bleed, they had to give her transfusions before the blood was really monitored. She likely was exposed to hepatitis C then. So we ended up going over to the blood bank doing a whole gazillion tests. And finally they found out she had this variation and she had to use something. She had to get injections of vasopressin, which actually increased clotting factors availability. That was genetically made whenever she had to have surgical intervention. So we had to order that shot. So just to let you know, so it's a well understood process in that regard. So once they're activated, they adhere, they swell, they become sticky. ADP plays a role, serotonin plays a role. Thromboxane A, again, names you don't necessarily have to remember, are in the form of what are called prostaglandins, chemical mediators that work locally and accelerate this process. So one of the things, when you take an aspirin, somebody who's had open heart surgery, for years, their prescription was a baby aspirin once a day. Aspirin stops platelet from aggregating. It inhibits thromboxane A from being released or activated. So it gives you, we understand this process. Sometimes it's very simple, and that's one of the problems with certain things that we take. People who take for surgery, we don't let patients take for about a week to 10 days fish oil, which a lot of people take because it helps their circulation. Trouble is, it increases the circulation, but it can increase bleeding. So typically, if they'll tell you, you'll get a call from the operating room. We have you scheduled. in 2 weeks for this. What medicines do you take? Okay, you can take this, you can't take this, but you can't take this. They'll all do that. It's routine. Again, this is one of those unusual positive feedback cycles. As they stick together, it increases the release of more chemicals and more of them stick together. What ends that is when the clot forms. And that's what positive feedback is. It ends when the event has concluded, so to speak. When whatever the goal is accomplished, like delivering a baby, vaginal. So, and it's different whether you're in a big vessel or a small vessel. So what happens once that occurs, once we get this aggregation, we see the change of the dissolved protein, which we're going to see at length, called fibrinogen, becoming fibrin. Okay. And that basically is like a fishnet that will hold red blood cells and eventually tighten them and form a real clot. So it goes from liquid to gel, and it involves a series of reactions. You don't have to know all these. I'm just going to give you an idea of the distinction between the two pathways. So there's a whole lot of them, and we'll talk about some of the deficiencies. Famously, hemophilia typically involves with something called factor VIII. So you need to know that. That's the classic hemophilia, which is, interestingly enough, the crown heads of Europe in the 1700s and 1800s, they all, politically, they intermarried. Maybe that's the wrong term, but the child of the king or the queen would marry the child of a king or a queen in another country, so they wouldn't go to war. So they formed a political alliance. Queen Victoria had 8 or 9 children. She carried the genetic marker that led to hemophilia in the crown heads of Europe, and probably was there before she was there. And she reigned a long time, not as long as the late Queen Elizabeth II, but almost as long. History. There's a great series on PBS that you can call Victoria. It was 3 seasons, just wonderful, brilliant. Just saying, it's really good. So I mean, there's a lot of interesting stuff that went on there. That was one of those interesting ages. So we'll take a look at the phases. So vessel is damaged. That would basically be a small vessel or a capillary, and it damages. The muscle contracts reflexly. At that point, we see the plugs. Then as the platelets accumulate, they release more chemicals, and eventually that fibrin comes out of the clotting cascade, and you'll see that shortly, how that all works. There's a lot here, I know. So, 2 pathways. Intrinsic pathway happens all of us all the time, slowly. Minutes, when I say slowly. The extrinsic pathway, injuries, happens much more rapidly, but fortunately for most of us, much more infrequently. Okay? Tissue damaging events. We call the clotting factors procoagulants. That means inactive. And it's a whole series of one forming inactivates the next and the next and the next. And all roads lead to the activation of factor 10. There's about 8 steps on the intrinsic pathway. There's about 2 when you cut yourself. Okay. Factor 10 then basically forms something called a prothrombin activator. And you'll see it here. Marker out. Not an indelible marker. They'll yell at me significantly. Hello. So it kind of looks like this. So effectively, all of them lead to this stage. It's called prothrombin activator. When that forms, effectively, that changes. So it's an enzyme, so it works here. Prothrombin to a chemical called thrombin. And then the thrombin changes the dissolved protein, the threads, fibrinogen, to fibrin. And then at that point, fibrin forms this fishnet apparatus. So again, it's a very well understood pathway. Again, multiple steps intrinsically, one or two steps extrinsically, which you will see there. And so all those factors, and what makes it a cascade, and what makes it positive feedback, every time the next factor forms, it increases the amount. You start with a little, and the next step, a little bit more, and a little bit more. So we call it self-amplifying. That means you make more and more stuff as that process is going on. And that's really the interesting part about this. So, and I know you're all looking at me like, do we really have to know all this? And the answer is probably not a whole lot of it. All roads leading to factor 10, that thing, prothrombin makes thrombin, fibrin, which catalyzes fibrinogen to fibrin. That's the key issue here. So intrinsic, because the factors are there, exposure to collagen, particularly even the glass of a test tube. So when they put blood in a tube, eventually you're going to induce the clot. If when you go and get blood tests drawn, they have all those different colored top tubes. You've all seen that? They have different stuff in there. Some of them have nothing in there. Some of them have calcium. Some of them have something called EDTA, which is detergent. But it stops it. So all those different tubes are there for different tests to be performed, either to induce clotting or not. So if you're in the lab field, you learn a lot about that type of stuff. Most of the folks lab, the venipuncturists, I mean, they'll see the list of tests, they'll know what tubes to pull. And a lot of times, it could be one or two, it could be 6 or 7. Extrinsic pathway, because the factors are outside, that's called tissue factor. That's what happens when you damage a cell in the exterior. Tissue factor is released, also called factor 3, and it bypasses the steps. And they'll show it to you. So it's a very elaborate pathway. No, you don't have to know. Extrinsic. Tissue factor eventually, very, very rapidly, effectively takes this factor 7, activates it, and it immediately acts as the catalyst to activate factor 10. They use Roman numerals. And once that's activated, now effectively, almost instantaneously, that prothrombin activator forms. Normal wear and tear on the blood vessels, factor 12, factor 11, and you see each one, once you activate 11, okay, activates 12, then activates 11, 11 with calcium, factor 7, activates 9, 9 activates 8, 8 complexes with 9, that leads to 10. Again, well understood. Don't have to memorize it or anything like that, thankfully. But a lot of steps, it takes more time. So it's a slower process. It happens all the time. So the prothrombin, once that's activated, prothrombin to thrombin, as you can see here. Okay, so the thrombin converts fibrinogen, which dissolves, into fibrin. The fibrin traps cells and they form that gel, and along with calcium, they activate another factor that stabilizes it and cross-links it. Okay, and so what happens when we have somebody who is on, most of these clotting factors come from vitamin K. So we have certain medicines that restrict or interfere with that process, and those are and we still use them. They're available orally. They have more side effect problems with bleeding and are hard to manage, and that's called Coumadin or warfarin. And then others that's used in the hospital called heparin. So in a hospital, let's say you're going to have a patient, some of you, that you're going to be doing a procedure or a test on, they'll have what's called a heparin lock already installed. You won't have to start the IV. Did you learn about these as yet? Okay. You'll take a little, the lock will be basically a portal that's sticking out. You'll expose it, you'll flush it with a little heparin, or break up the little clots in there, then you can put your own medication. so you don't have to keep sticking somebody 58 times. I was a human pincushion back in 2000. My arms were totally black from being stuck. I was in the hospital for about 3 weeks, mostly on it. And so anticoagulants work that way. We have more advanced ones. So here, the fibrinogen, once it's activated, then it becomes insoluble and it cross-links. So you can see the different phases. So you can see here, prothrombin makes thrombin, the thrombin then makes the fibrinogen, and voila, that's what the clot looks like. I love that slide because it really shows you what happens in clotting. And the other neat thing is that imagine if this is happening all the time in your blood vessels, shouldn't they all be all clotted up? They're not, because as soon as they start to clot, we have another mechanisms to dissolve the clot. The clot's there. Once it's repaired, it disappears. Okay, and they have a whole list of all these things where they're made. Clots stabilize. Elements that we see in muscle, actin and myosin, contract, squeezes out the serum. Serum is, and we hear the term serum versus plasma. Plasma has clotting protein. Serum is the fluid from clotted blood that's missing the clotting protein. So there's a difference between plasma and serum. That's the difference. It's absent the clotting proteins that are there. And so we start to see platelet-derived growth factor released. That plays a role. There's something called vascular endothelial growth factor, also restores the lining of the blood vessel. So again, well understood process. And so clots are removed within a couple of days, the process starts. And there's something, and it's got another pathway called plasminogen to plasmin. And it's activated by some of the clotting factors, factor 12, thrombin, names you show over here, and something called TPA, tissue plasminogen activator. What they do in populations where they have a lot of elderly people at major hospital, they have that stuff, TPA already made genetically. And someone comes in with a stroke or a heart attack, if you catch it within the first X amount of hours, you can put a catheter in and inject that and dissolve the clot. My late aunt had that done in Florida, okay, when she was like in her late 80s. And I think she lives a good 5 to 10 years after to treat a stroke. Because, they have, and Florida's got a lot of retirees. So they always have that technology available. So TPA is something that is used a lot. They used to use an extract from streptococcal bacteria, but it was harder to control. So this is made genetically. So let's stop here. I'm sure you'll be delighted to not hear me talk anymore. If you have any trouble accessing that, let me know. I'll try to find a way, but hopefully that link on your phone will work satisfactorily. We'll meet here. There'll be plenty of time. I think there's only 60 questions. You'll have the whole period to do that. All right. And as soon as, hopefully, whenever they leave here. Thank you. Going back to let out the pooch.